You were gonna.
Jeff, can you use your YouTube? Yeah.
I need to start.
Yeah, we're good. Okay. Good evening, everyone. Ladies and gentlemen, thank you for joining us on this not yet spring, but nice spring day. This is the Tuesday, March 18th, 2025 REMAC meeting. We're going to start with a roll call attendance. When you hear your name, please say here or not here.
Joseph Schenker,
Here.
Michael Batch, Robert Ackerman, Laura Evapoli, here, Stuart Kessler, Kelly Hastings, here, Kevin Mangel, Cindy Basilios, Grace Cacciola, here, Dario Gonzalez,
Here.
Glenna Seda,
Here.
Bradley Kaufman,
Here.
Nathan Reisman,
Here.
Paul Lai, here, Nicholas Alexandru,
Here.
Doug Isaacs,
Here.
Ward,
Here.
Anne Marie Giorgenti, here, Andrew Dahl, Allison Burke, Jeffrey Raybridge,
Here.
Lauren Costarco, Reed Caldwell,
Here.
Jonathan Berkowitz, Michael Redliner,
Red.
Eric Luttinger, Paul Barber,
Present.
David Benelli,
Here.
Christine Chen, Mary Foote, Mark Cantor,
Here.
Ed Jarvis, Nicholas Ficari, Joseph Faux,
Here.
Jessica Van Voorhees, here, Benjamin Zabar,
Here.
Matthew Harris,
Here. Really want to say not present.
Robert Krupe,
Here.
Arthur Cooper, Yadivya Langsam, Anthony Shalish, Warren Strowman.
Great. So we do have a quorum, so we will conduct this meeting tonight. Next, I'd like to go over the approval of the February 11th minutes. These were sent out via email. Does anybody have any questions about the minutes? Any corrections to the minutes? Motion to approve the minutes.
Motion to approve.
Second? Thank you. So we will take the minutes as approved and move on to the correspondence report. So I will preface this by saying that the correspondence report has some items that I'm sure we are going to discuss. When we get to those items, we're going to discuss them and then move on to the next. I'd like to keep the discussions relatively controlled. If you have something new to say, that's great. To reiterate things that have been said already, we'll be here all night, and I'd rather not do that. Okay, so let's begin with the correspondence report. So first, from a membership perspective, Dr. Nicholas Alexandru has announced his retirement and resignation from the REMAC committee after this meeting. He did email us a letter, which I'd like to read into the minutes and for everybody to hear. Dear Executive Council, REMAC Council, and REMAC board members, after 27 years of serving on the New York City REMSCO and REMAC committees and 25 years of employment with the FDNY, I will be retiring from my positions at FDNY and stepping down from my position on the REMAC Council. March will be my last meeting. It has been an honor and a privilege to work with so many wonderful, talented, and experienced people, professionals, and agencies in the field of emergency medicine. I have seen and learned from the best in the country and have seen this council achieve the best in pre-hospital emergency care. This is proven by the fact that so many regions, including at the New York State level, have incorporated many of our ideas and protocols into their regions. New York City and this regional council are so large and unique that although we are part of the New York State Council, we require the autonomy to lead and have proven that in so many ways. Everyone here has contributed so much in their own way with the same focused goals, and that is to provide the best pre-hospital care and services to our public at their worst times in their lives. This council is the first line medical response of our public agencies and all of the hardworking pre-hospital care providers, CFRs, EMTs, and paramedics in New York City. I am proud of the work, hard decisions, and accomplishments that were made throughout my years, which followed and continued to build from successful experiences of our prior members. Many lives have changed and saved due to the progress that we have made and rapid responses that we provide to our public, well demonstrated by the initiation of emergency programs such as STEMI and LVOs and the emergency preparedness and responses to Ebola and COVID epidemics. Looking back, this experience and participation within this exceptional council and group of minds has been one of my most gratifying experiences of my professional career. It says in my professional career, but I think it's else. Thank you for the opportunity to have served and worked so closely with all of you throughout the years. I will miss all of you. Nick. I would like to thank you personally. If you don't mind, I know you didn't want me to read this, but if you wouldn't mind saying something, I would really appreciate it.
Yeah, it was been a pleasure working with everyone throughout all these years, just like you said. I'm very humbled by the opportunity that I had here to work with everyone throughout the years. And it really has been a tremendous experience moving from the past into the future of all these years and what we've accomplished. And I think it's just a wonderful group that we have here, continually striving to do better and better for our citizens of New York. And wholeheartedly, I just want to say thank you to all of you for this close relationship and working together. Thank you.
And we thank you too. Okay. Next, Dr. Anthony Shalish has requested to return to his at-large position from which he was removed due to attendance. He did attach his CV. It was sent to the committee. We will forward this to the membership committee. I would like to give him the opportunity to explain why he feels that he will be better fit for this position after being removed, but he's not here yet. So maybe if he gets here tonight, we'll have him speak. If he doesn't get here tonight, then we will have him speak at the next meeting. Anyway, okay. We did not receive any correspondence from FDNY EMS. We did receive correspondence from the Department of Health. We received an FDNY directive from the Department of Health, EMS OGP 115-8, which is effective March 12, 2025, which outlines patient transportation to the closest 911 ambulance destination as recommended by the CAD. This was sent out to the committee. I know everybody got the document. I'm not going to read this whole piece here. There's also another directive, 2502, which mandates that all patients be transported to the facility determined by the hospital suggestion mask, and crews shall not override the CAD recommended hospital. So I am going to allow Dr. Aseda to briefly speak on this, and then I'm sure there'll be a discussion. Dr. Aseda, the microphone is on. There you go.
Thank you. All right, so this thing went out Wednesday afternoon, and immediately I started getting phone calls. And I have to tell you that our commissioner, the FDNY commissioner, has been quoted in the newspaper as saying that EMS is about to collapse. Right, that's in the paper about 3 weeks ago. So one of his things is that internally, because of the promotion of EMTs and paramedics to firefighters, we're about to lose 1,000 EMTs and paramedics going to the fire side, onto the fire side, with about 350 coming behind. So it's not sustainable. That's a city issue, and that's our internal issue. I understand that. But one of the things that he's charged with, and his mission has been to see what he can do about reducing response times, trying to see what we can do about turnaround times, see what we can do to get resources appropriately and all this. So one of the things he had asked was, why do patients have a choice as to what hospital they go to? For the most part, the stable patients, low index. And I didn't have a great answer for him because all I could say was, because we do it that way, right? So ever since this thing went out, Greater New York Hospital also sent the commissioner a letter, which he forwarded to us, essentially saying they wanted everything to be delayed because they felt that as stakeholders, they should be involved. But one of the biggest issues that I hear, and I know you guys hear too with your medics, your CME sessions, why are we just a cab service, right? That's the biggest thing that I get. And the commissioner is correct. We are an emergency service. And so this choice of going for a stable, low index patient, being able to have that 10-minute rule, 10 minutes from the closest hospital, and if the EMS supervisor on scene another 20 minutes, we just can't sustain that. 1.6 million calls a year, right? I mean, it's just not possible. And, you know, voluntary sides, you guys have been helping us out the best you can, but it's just not sustainable. And so with stable patients, we're not going to allow you to go to a hospital of your choosing anymore. And the old plan of, oh, because my records are there, it's not going to fly anymore. And what's going to happen is some people are under the wrong impression that they can only go to the closest hospital. That is not correct. The hospital from the incident location, the 2 to 3 that you can get to within 10 minutes are hospitals that you can choose. Now, Greater New York is very concerned because Allison Burke called me and said, well, what about this continuity of care? I get that. And there are going to be cases where you have to get to that facility. But If you have a stubbed finger and you're across the street, let's say from Coney Island Hospital, and you need to get to a New York Presby facility, I'm just using the name, it's not gonna be allowed because the state certification of 911 receiving hospital says that they can handle your stubbed finger, right? What is gonna remain as is now is the specialty hospitals, particularly like the Sloan Kettering, the VAs, the New York Eye and Ear, where they're not emergency departments per se, they still will have to call online medical control to get permission to go there. Partly because online medical control, the physician's gonna have to contact the facility to say, hey, do you have a physician, do you have staff there that can take the patient? New York Eye and Ear is a great example. There are oftentimes is no one there for us to send the patient. We can't go there in certain cases. The VAs, obviously VA patients, that makes sense. The other issue is the specialty, the traumas, right? You're gonna go to the closest trauma center, the burn center. The patients that are LVADs, that's gonna be a specialty kind of a case by case where we're gonna try to get you there. But we get 800 calls a week just for a transportation decision. We can't sustain it. We just can't. That's 40,000 calls a year. And the choice of going to the facility when you're a stable patient, where the closest, not the closest, the 2 to 3 emergency departments, state certified, can handle your sprained finger, that's what you're going to be offered. And I've tried to change the language in my MAD. The MAD is something I wrote, right? That the ops guide is something that Chief Cattell can speak to on that end. But the MAD tries to address the fact that we need to change the language, I think. It's not really an RMA. And when I'm in we're not refusing to transport for your stub finger. We're just saying that we're offering you these 2 to 3 hospitals that they can handle your stub finger. You're declining the transport we're offering, right? We just need to change that language. It's not refusing you. And maybe we have to come up with a new 10 code internally, but that's the policy. But specialty thing, if you just had surgery and were discharged from, and I'm going to use Brooklyn because I'm still part of Brooklyn. If you had surgery at New York Methodist and you live yesterday, I'm sorry, and you were discharged yesterday, and you live across the street from Coney Island Hospital, and that wound is opening up, and the crew gets there and says, wow, there's pus coming out of that wound, and it makes more sense to go back to New York Methodist because that's where surgery was. Can Coney Island Hospital across the street take care of you? Of course they can. Of course they can. But for the patient's benefit, it's probably better to try to get them to Methodist. That's a call that's allowed to be made to online medical control, and that physician can say, hey, you know what, that makes sense. Looking as an ED doc, right? If we got that brand new patient doc, we can handle that patient. But does it make sense? It doesn't. But the fact that, oh, I need to get up to New York Cornell because my records are there, that's gone. That's not a choice anymore. And so that is the plan going forward, case by case. It's going to happen, but we just cannot sustain the volume. We cannot sustain the 800 calls for transport decisions. The 10-minute rule is no longer in effect. And that's what the change is. You know, why do you get all these choices? I don't think you need to. I think that the 2 to 3 that are within 10 minutes of the location for the low index, minor type injury or illness, they can be handled at the state certified 911 receiving emergency department. And that's our plan going forward.
Right. Thank you. I'm sure there's a bunch of discussion. I know Matt and then John. Oh, Grace, you want to add something?
Just wanted to make everyone aware, the operating guide procedure that is attached to today's minutes is not the final. We currently are working on it, and a new order will be coming out tomorrow, which we expand on Riker Island transports, mental health 958 transports, and we just clarify the specialty referrals a little better. So this is not the final document.
Thank you.
Yeah, thanks. Look, I certainly applaud the effort by the fire department to do anything we can to reduce the strain on the system and to improve opportunities for retention. I'm not sure any of these are going to achieve that. I think it's shifting responsibilities to the interfacility groups, because ultimately patients, and the BLS patients, I think you could very easily say they should go to the app if they even need to go to a hospital. They should absolutely go to the closest hospital. I don't think anyone's going to try to justify a BLS call type. But the complexity of care in the city has grown. It's not really a function of records. If someone had a kidney transplant and they have an issue, they should go back to their kidney transplant hospital. If they've had cardiac disease and they've had 3 stents placed at NYU, they should go back to that hospital. It's the patient-centric thing to do. It's the clinically appropriate thing to do. And on the back end of this, this will just increase the congestion of interfacility transports and ED length of stay and EDs that are already overburdened. So I think I don't have a solution, so I'm complaining without a solution, except to say that I think that this is not going to accomplish the goals it's aiming to do, and will increase the burden and just shunt it to a different part of the system.
Thank you.
I mean, it may, but that option is still available. Somebody had a kidney transplant at that facility, that is a call that you can make to the online medical control physician and discuss that case.
Hey, Rob?
Yeah, it's not just the patient or a kidney transplant. I mean, we have an aging population and we have a lot of chronically seriously ill patients. Okay, they may be under the care of like multiple subspecialists. Okay, and again, for the low index thing, yeah, fine, stub thing is fine, but okay, but where people got renal, cardiopulmonary issues, okay, we have to understand that not all community hospitals are equal. Okay, even some locales, okay, there may be a difference between one community hospital being an academic teaching hospital, tertiary hospital, okay, and another hospital, community hospital, okay, it's not academic teaching hospital with very low capabilities. Okay, so that's my concern. I don't think it's just about continuity as some sort of like lofty principle. It's about how do you actually take care of the patient. And I would imagine in my community, okay, a lot of patients going to one of our local community hospitals that we follow. I can imagine them refusing to be admitted to those hospitals and requiring transport. Okay, that's going to take time, depending on the time of day. That patient may be there for hours for transport to happen. Like, it actually may have the unintended effect of backing up an ER. So with patients, okay, and it causes more damage to the system, okay, than we would hope to fix.
Well, then let's come up with new standards and get rid of those hospitals that we think suck.
Yeah.
I don't know what to tell you. I mean, something's got to give, right?
Okay.
And those cases are case dependent. You can't speak to the physician. We're not
Okay.
saying no. I mean, I'm saying kidney because you're saying kidney. I'll say cardiac. You say cardiac. You say stroke. I'll say the same thing. I get it, but
Yeah.
I see what you're saying, but we got to stop.
One second.
The low acuity.
I got
stuff
everybody, I
there is
promise.
the kind of call that we got to stop going to.
Okay.
Because my records are there. We can't do that.
Guys. Bob,
Address the chair.
there's a lot of people who want to speak. I know that we can have this conversation all night long. I understand your point, Bob, and I understand, Glenn's point. Let's move forward because there's other people that want to share. Jeff?
Thank you. So I appreciate Glenn's comments and I absolutely agree. The low acuity, stub toe, that kind of stuff. I don't think, that's not my concern. My concern is the person with the complex medical problems, medical needs who is potentially ill and may choose to RMA or not go because that's the option they're given. And then concern about a bad outcome of them at home or not being transported. And with these patients with complex needs, I agree with what's been said that, there's continuity of care, there's complexities, that they need to see their own specialists. And I don't have a great solution. This just doesn't seem very patient-centered for those patients, but I agree, we have a real problem that we have to address. And maybe if we carve out those real low acuity patients, maybe that's a starting point, but I do have concerns about this potentially sicker patients.
Thank you. Dr. Caldwell.
Thanks for providing further clarification on the order that came out with no early warning or communication to any of us ahead of time. I have 3 questions I'd like to ask regarding this. In the example that you gave regarding the Coney Island patient with the open abdominal wound who'd had surgery at Methodist, what if the crew just doesn't feel like transporting the patient to Methodist?
Let me tell you something. This happens all the time when we do our QA/QI stuff right now. If you think this is going to happen because of the change, you're not in the same system. This happens all the time right now. Do you know how much QA/QI we have to do to say you RMA'd a patient that you didn't identify was high risk? Are you kidding me? And now they're dead. We're going to call back 5 minutes later that they're in cardiac arrest. I mean, you're kidding yourself if you think this doesn't happen now.
Okay, thank you. My next question is, one of the things you cited was that the online medical control telemetry is overwhelmed with calls. Don't we anticipate this would drive the number of calls up?
Initially, I think it might be because they're going to call us 5 times for the low index. I've already directed telemetry to say to the crew, no, tell them you're not going to speak to the physician. This is a low index, stable vital signs. It's denied. And at some point, I think patients are going to go, crap, don't call 911, call a cab. You can't get where you want to get to. And that's what we need to do.
Okay, and lastly, for patients that have very complex disease processes like transplant, doesn't this charge the medics on scene and the online medical physician with understanding the intricacies of all of those, all the complexities and risks associated with those complex cases?
Again, do we not get those calls today? I don't understand. You think tomorrow it's gonna change? I don't get it.
I
We
think
get
the
these
number
same
of calls will
transplant
go up.
patients Yesterday, today, tomorrow. I don't see I don't get the point of that.
Laura and then Mike.
You go to the nearest hospital and get stabilized. And then once you're stabilized, referred to the center if you need to be where all of your records are. But if you're calling 911 for a stub toe, you should be taking a taxi, not calling 911. And if it's a routine issue where all your records are, you should be going there for your routine care. If it's an acute illness, you go to the nearest hospital that's capable of taking care of that acute problem.
Paul, then Michael, and then I'd like to try to wrap up this discussion if possible.
Thank you, Glenn and Grace for speaking to this. In principle, I agree with it as well, regards to the streaming 911 system, because I think we all are partners here together. I think we sit in this room as partners. But I don't feel like a partner in this process. I feel that this process was passed without any input from the voluntary system, which comprises what, 30 to 40% of the human resources of the 911 system. And it was basically handed down with an edict to take it. And I will assure you that this would have been staged or piloted in a period of time or in a geographic area, but it was not. It was simply a light switch on a Thursday night. Now, I want everyone to know that there are dangerous staffing facilities and hospitals in this city because of this process. Hospitals that are not used to receiving the volume they're getting are getting that volume. Maybe some geographically isolated areas in the southern aspect of Staten Island, maybe. The lack of input and sharing in the process is the issue I have. In principle, yes, if you call 911, you should go to the closest hospital. And yes, the healthcare system expects people with complex cases to go back to their facility on the back of the 911 system, which is inappropriate. We should be engaging other methods of delivery. But to have this go so abruptly without our feedback, I do not feel like a partner in this process. And that's my issue.
Thank you. Michael?
I appreciate everybody's comments here, and I understand the dynamics and needs of the 911 system. I mean, I think we've been talking about this idea for 10 years, right? About trying to get low acuity patients to a different methodology. I echo Paul's sentiment. I think it was a surprise to everybody. And the one thing that I would just highlight that I think affects everyone who's working the 911 system is that this changes the dynamics between the frontline providers and the patients. And right, it makes it more contentious. It makes it more prone, potentially to having patients who are upset, potentially violent. So I think that there's a lot of repercussions that I've already heard in the emergency department from the EMS providers who arrive that I think we need to be very thoughtful about. We need to prepare our frontline providers for those conversations. I think that's another element that I would just bring into the mix as we think about what are the impacts of this. And so, again, I think we can solve the problem. I think we need to solve the bigger problems. But I think that's another symptom of kind of the abruptness of the announcement that I've heard from colleagues across emergency medicine.
It's interesting that you bring up the confrontations. The unions brought that up too, but then it died down. I think because a lot of the membership are saying it's about time. Some people that have been retired apparently have come back online going, man, I wish they had done this when I was there. Again, I can't speak for other people, but that's what's been told to me. And the union has not approached us. Initially, they're saying, well, they're going to be more now in a hostile environment. I hate to say it, but every day we walk onto the ambulance and out of the ambulance, we're walking into a hostile environment potentially. So that's there. You're right. Maybe there will be some increased calls, but the last thing we want is any of our members to get assaulted, but we just cannot sustain the system the way it is.
Yeah, I apologize. I'm late into this conversation. Obviously, we've heard from a number of hospitals and members about the concerns with the new policy, particularly around continuity of care. And I think what we're trying to really understand too is what is the definition of low acuity? That is one thing that doesn't seem apparent to us. Granted, we're not clinicians by trade, but we've been getting a lot of questions about that. So I'm curious if there's a definition of low acuity and if that's better defined.
I mean, I think the current policy, which is not changing, is that patients who meet criteria for specialty centers, trauma, burn, stroke, replant, hyperbaric, STEMI, LVO, stroke, have to go to the closest specialty center. So that's the current policy, and that hasn't changed. So basically, anyone who doesn't meet one of those criteria, which, for 911 would be, GED, PEDS GED, basically would go to the closest within those choices like Glenn said, the 10 minutes or whatever.
Right. And I guess instead of trying to reiterate at this meeting what is low acuity, there is a document that very clearly defines it. That it's a fire department's ops guide that we can send to you so you can review it and show it to people. I think what we're hearing here is that everybody agrees that low acuity patients either should take a cab or go to the closest hospital. The challenge becomes is how are crews going to respond when it's a higher acuity patient? Will that change? Glenn is saying that this happens all the time, that even today crews are, families are upset when they're told that they can't go to a specific hospital or whatever it might be. I think it will be a learning curve to see how this translates and how this policy change. If it changes the attitude of the providers to say, no, you can only go to the closest hospital, but my cardiologist is at this hospital and I'm having chest pain. So I guess we're going to wait and see how that develops. It's going to take time to really, I think we all agree that for low acuity, you either should not take an ambulance or go to the closest hospital. So I think that part is clear to most of us. I think that this is a discussion that we can continue all night. I really don't think we're going to have any new answers until we start to see how this policy goes into effect and how it affects both the volume at online medical control, as well as patient satisfaction, as well as hospital satisfaction. So maybe this is something that after EMS week in June, we could get some feedback from FDNY as to how this policy or everybody in this room, how this policy is affecting all of us, and see where we go from there. I think that's probably the best next steps.
Yeah, Dr. Shaker, I appreciate that. If we could get that policy, I think we've just been trying to get our arms around it. Dr. Zabar, I appreciate the definition there. And I think it'll remain a concern about continuity of care, unnecessary secondary transports, and I'm sure it's been said already. So thank you, guys.
No problem. All right. So one last question, then we're going to move forward. Go ahead.
About what are the metrics we can expect to be reported out by the fire department to this group to reflect the impact of these changes?
I don't know. Quite honestly, I don't know. I mean, we're going to QA/QI this. We're going to contact our own medical control. We're going to see what the volume is. We're going to make sure that we're not harming patients. That's something that we're always doing all the time. But I can't tell you what the metrics are.
Okay. I mean, again, I guess if people do have suggestions as to what we can look at, maybe forwarding them to Office of Medical Affairs might be helpful to help define what we can look at. Maybe the number of telemetry contacts, if that goes up, maybe the number of secondary transport, well, that we'd have to get from other agencies, but the number of callbacks within 72 hours. I know you guys do track how many, like an RMA that gets a callback within a certain amount of time. Glenn, do you track that?
Yes.
So, I mean, I guess those are things we could look at to maybe get some answers.
You can also suggest diversion requests.
Well, I think that's something that we can, I think it's a great idea that we could send to the committee in an email so that we can have those numbers and share it and see where we can go with it going forward. Right. But you have to turn it on.
Turn it on.
There you go, Pam.
Well, I mean, so like I said, so this is something that the fire department is taking seriously in terms of taking a look at the QA/QI for this and the impacts for the system. This is something that we are still going to be under development as we speak, but it is going to be something that we will be keeping a close track on.
Great, thank you.
Is there an anticipated start date for this?
It already started.
Already started.
Yeah.
So the
On March 12th.
documents are deployed on Wednesday, whatever Wednesday
The
was.
12th, I believe.
The 12th. And
That's right.
so it's been in effect since then. So interesting you bring up diversion, just as a point of reference here. Diversion is a courtesy, right? 50% of the MS systems throughout the country do not offer diversion. The closest large system to us is Boston, right? I speak to my counterparts all the time, and when they say we've not offered diversion for 15 years, I call bullshit. Why? Because if the hospital's on fire, you're not going to say to them, that sucks for you. Good luck with the patient. You do not offer routine diversion, but these the trauma surgeon got sick, you have no trauma surgeon. You're not going to bring a trauma patient down. Right? So that no diversion is not true. However, this routine diversion is not there. We're getting to the point where we may not be able to offer it in the system anymore. Why? EDPs are a problem right now. Nobody wants them. Look at your own facilities. Nobody wants them. A couple of years ago, we looked back at it. Of our 1.6 million calls per year, 10%, 160,000 calls are EDP a year. That's huge. They're trying to be heard. They try the frequently utilized, the FU program, I call it, right? All these different things to try to figure out what to do. And it just isn't working. So we met with the Office of Mental Health state level and most of the players that accept psychiatric patients. And we went over the numbers, and Chief Bastilli at the time had numbers for 2 years. And we said, this is a problem. Diversion is a courtesy. No, 50% of the system doesn't offer it. We're getting to the point where maybe we'll start with EDP, where we no longer can offer diversion anymore. And of course, they balked. No, we don't want this. This is that. Some of the CPEP facilities, and we don't have enough. One said, well, you should take all your psych patients to CPEP facilities. You want a higher level of care. At the time, I think we had 8 or 9. Funny, I said to the one person that brought it up, you as a CPEP center are saying, bring these patients to you. Let's look up your hospital. Out of 365 days in the previous year, you were on diversion 225 days of the year. It's not possible. And what's happening is we're getting crews from Lower Manhattan going into Central Brooklyn because nobody's taking EDP patients. So we're getting to a point where that's probably going to be our first no more diversion. And then it's probably going to expand. We just can't sustain this anymore. So the diversion, which is a courtesy, and everything's in a hospital pod, 3 to 5 hospitals at a time. So if 2 of a 3 hospitals go on EDP diversion, guess what? Everybody's open because we can't do it. And it's a courtesy that we try to extend. 50% of the country laughs at me when I go to these meetings. Are you kidding me? You still do this? We can't sustain that either. That's something we've been looking at for the last couple of years. And when I went to the mental health people, I said, give us some solutions. Help us to figure out what to do. Nobody's gotten back to us in 2 years. So that's where we stand on diversion.
All right. One last comment from Laura, and then we're going to move on.
Well, Elmhurst is the regional EDP receiving center. So, no, I'm kidding.
We'll bring them all to Elmhurst. No problem. You heard that, Glenn, right?
I'm totally joking though. We
Oh.
used to have the very briefly, it was I don't remember exactly what it was, but it was after COVID and it was something that got turned on and off when
Redirection?
Yeah, the redirection. I don't know where that went or
It's still there.
and it still gets turned on and off. Because if you go away with, diversion and that actually works, that would be the solution.
It's still in place. I think that the CAD will not recommend you if you are on redirection, whatever the number is. So that is still in place. And maybe that with this policy, maybe that will work. But again, I think what we've all agreed on is that until we have some data, we're not going to know how this is going to affect the system. So I think we have to kind of wait and see a little bit right now. Last thing, but then we're done.
Are thrilled with this because they feel like they have some control and they are not just playing car service drivers.
Agreed.
So
And
we need
I would
to-
be too.
Yeah.
My concern is that sometimes for those patients that shouldn't be going to the closest hospital, they're going to be thrilled about taking that person to the closest hospital.
But
That's, I think, the concern.
that occurs daily now. and
Correct. Understood.
That we are going to be monitoring this very carefully. Hopefully, we will be able to weed those out and re-educate those crews
Excellent.
as needed. And I'm sorry that the voluntary sector felt like we did not include them in this. They are important. They are a very important part of the 911 system and make up 33% of our 911 system. And we are very appreciative of that. especially with the amount of people we're going to be losing in the very near future.
Okay, moving forward, I have to get back to the correspondence report. Okay, so there's some enforcement items that I have to read in. Ronald Jocko Jr. from Hyde Park, New York. EMT number 328110 is suspended for 1 year effective 2/27/25 or until such time as he completes a full refresher, and he was fined a civil penalty of $2,000. Ryan Morgan of Pleasantville, New York, 438642 is suspended for 1 year effective 2/21/25 for some Part 800 violations. And those additional enforcement items can be found on the DOH website. There was an iGel pilot program submission, which we're going to hear about during the QA report, so I'm not going to read it right now. There was a submission from Northwell through an anonymous source that a memo was sent to REMAC, which no longer requires that their paramedics who do not work in the 911 system in New York City are not required to maintain a REMAC certification. So for Northwell paramedics who do not work in the 911 system, they will not need to maintain a REMAC certification. I have spoken to Dr. Berkowitz about this. He is not at this meeting. We will bring this back under unfinished business at the next meeting to discuss it with him. Clearly, any paramedic that's operating primarily in the New York City region, whether they are 911 or not, needs to be REMAC certified, and we have to be sure that that is clear to everybody. But I will allow him to clarify his directive at his next meeting. Okay. Finally, there was a letter sent to NAMSP regarding the cyano kits that was sent out. And finally, and most importantly, I would like to congratulate our own Joe Ranieri on being appointed to the permanent position of Executive Director of REMSCO. We know that he's going to do an amazing job, and he's earned it, and we welcome him as the no longer acting, but the Executive Director. Thank you and welcome, Joe.
Thank you, everyone. Forward to working with you all in this new role and doing some great things together.
Closer to the mic, Joe. Come on. Of all people.
Thank you, everyone. Looking forward to working with everybody here at this table in this new role and doing some great things together.
Okay, so that concludes the correspondence report. Are there any questions about the correspondence report that we haven't had already? Okay, great. We're going to move, the executive committee did not meet. We're going to move to subcommittee reports. I'm going to go a little bit out of order and move QI to the beginning because Lauren is going to be presenting and Mike's son's bar mitzvah is this weekend, so he might need to leave a little early. Mazel tov. So we'll move that first. Lauren, Dr. Kosterka.
Can you hear me okay?
Closer to the mic, Lauren. Come on.
Testing. Good? You don't look thrilled. Okay. The quality committee met virtually on February 15th. At that time, Mount Sinai presented to share their involvement with a NEMSCO National Airway project called Airway One, which focuses on first pass success of endotracheal intubation without any hypotension and hypoxia. So it's not possible for us to join this regionally at this time, but I think we'll plan on using the findings and lessons learned there to focus on data regionally, just to make sure we're aligned with national guidelines and best practices. So thanks to Sinai. As Joe mentioned, Bedford Stuyvesant Volunteer Ambulance Corps has applied to participate in the BLS iGel project. So we reviewed their application and the quality committee is supporting that.
Yeah, the application is complete. They have approval of the Hudson Valley region. So we will submit our approval so that they can start the project. They will need to submit any usages to the QA committee for review.
We need to send their application to the REMAC or?
So we're going to send them back a letter signed by either Joe or myself to saying that they can now operate their application is complete. They then submit that to Hudson Valley, and then they can start operating in the project. Might have to hit the button on the projector. Oh, there you go.
So we were asked to review the currently participating agencies that are doing the BLS iGel pilot. So that's what I'm going to just briefly go over today. As a reminder, this was a pilot that was announced by the state in January, I think, of 2023. And here are the main elements, the requirements for participation from agencies. It's patients in non-traumatic cardiac arrest. They're required to use an iGel recessed pack device. Waveform capnography needs to be used with each placement of the iGel. Every airway placement needs to be confirmed at patient handoff by a higher level of provider, so either ALS or somebody in the ED, whether it's physician and PEPA, et cetera, and signed off that the area is confirmed and evaluated by them. All aspects of use need to be documented in the EPCR, and all of the participating agencies have to engage in timely quality assurance and send all of their data to the Hudson Valley REMSCO. So the time period that I'm going to focus on today is from January to December of 2024. At that time, we had 3 participating agencies, which you'll see here are Jamaica, Flushing, and Gotham Volunteer, formerly Ridgewood, I believe. I hope I'm not getting that wrong. As you can see, there were no uses for Gotham during this time. So the data today that I'm presenting focuses on Jamaica and Flushing. The total attempts are in this first column here over the course of the year. So for Jamaica, 18 and Flushing, 17. Out of those, 16 and 14 were documented as successful placements, respectively. Here's the end tidal CO2 documentation. So the column there on the left is if end tidal was documented 1 time. And then the second column on the right is if it was documented twice during that patient encounter. And then that last column is just making, confirming that the signature of whoever received the patient, confirming airway placement, was documented. Very quickly, I'm just going to touch on the training process from Medisys, just because we thought folks would have a few questions on how this was rolled out. So again, this is specific to Jamaica and Flushing, but they did iGel training at their new higher orientation and all CPR courses. There were ongoing training sessions held during all their AHA BLS classes. They had biannual refreshes, and then there were opportunities for just-in-time training where they would take mannequins and iGel supplies to crew areas if providers felt they wanted more practice. Here were the challenges that were brought to us by Jamaica and Flushing. So the first one was difficulty obtaining end tidal CO2 levels. You'll note with the data previously, most of the iGels had documented end tidal CO2s once, but it was only 90%. And then for a second documentation, it was only 50%. The second issue here was acquiring signatures from the patient at patient handoff. So it was noted that there were numerous occasions of ALS refusing to sign off on that airway. And then in terms of dropping patients at the ER, it didn't seem like providers weren't always present when the crews were documenting, so that posed a challenge. And then in terms of actual challenges to placement, some of the things you might expect, secretions like blood and vomitus in the airway, a clenched jaw, and then just difficulty securing the airway device. And then 1 or 2 instances, it was noted the iGel was too small. So here are our main takeaways from the quality team. Overall, we thought that the data demonstrated that the pilot was pretty safe and effective. Our 2 main concerns that I think are the greatest areas of focus for improvement moving forward would be the inadequate end tidal CO2 documentation. You know, we all know this is standard of care for airway placement, and you know, I think that this should be 100% compliant. If you can't get an end tidal, the device should probably be removed. So I think this should be 100%. And then we discussed maybe there's some benefit from reevaluating the equipment used. I know at Medicis, they said they were using this EMMA capnography device, which was continuous as required, continuous waveform, but it didn't transmit to Health EMS. So they thought maybe that was a challenge and just like more a documentation issue than obtaining the value. And then just as I mentioned before, the missing documentation on airway sign off. A little bit concerning in terms of, this isn't a definitive airway, so we would want to make sure that the airway is being adequately monitored during patient care handoff when there could be displacement of that airway. And then also, there could be a role for improved communication and or education about this program, even if agencies aren't participating. I see this probably being an issue if there's like one agency that's participating in their BLS, they're handing off to an ALS agency that's not, and they don't have an awareness or a comfort with the project. So I think we could probably do a better time making them aware. And then I think moving forward, we can take this data and compare it to success rates of ALS placement of iGels and see if there's any difference there. And of course, continue to collect data. Any comments, questions?
Laura, I just might add to that, which I think is important to say, which is that in any airway program, not just the BLS iGel, right? We have imperfection. We don't have a perfect system where 100% of airways are documented. We're always striving to that. And I think it's a nice exercise to look at an agency's work to ensure quality in their agency. And this is a great example of that. It's imperfect, and they've identified the issues that are coming up. So I think it's sort of a model for all of us to say, hey, we're imperfect. We understand the reasons why. We're going to work on them and improve it. So, again, I think this is something that I understand is moving forward as a protocol at the state level. So until that point, it's still a pilot project. But I think it's something that we'll continue to see. And again, I think the quality effort around this will be important to continue.
You raised your hand. I don't know your name.
Christian Dupre.
Hey, just turn on the microphone and. There you go.
There we go. Christian Dupre, I'm the quality manager.
You're gonna get yelled at if you don't. There you go. Okay.
Christian Dupre, I'm the quality manager for Medicis, Flushing and Jamaica. And I'd just like to say that after that conversation, we did implement a couple of new changes. So we had more direct feedback after each use, and then also put in an easy to access document in mobile touch. So they have iGel documentation right at the tip of their fingers when they're performing the treatment. And we've noticed a 25% increase in multiple capnography documentation, and also a 13% increase in overall signature. So part of the QA procedure of giving them easy to access material on the documentation of it has dramatically improved in a short period of time.
Great, thank you. First Ben and then Doug.
Yeah, and I mean, it's a great project, and thanks for the analysis. I'm bothered by, there's this constant scope creep. I know there's been some discussion in the state about that, but that people keep doing these pilot projects and we're adding more and more to BLS, but we're not making the BLS course longer. And with 8 hours, we can train to do CPAP. With 8 hours, we can train BLS to do iGel. And I think that's all great and check and inject. But at a certain point, these pilot programs become standard and we're squeezing more and more things into the BLS program without necessarily making the course longer. And at a certain point, you start sort of getting towards the AEMT scope. So, if they want to add all these things to this to be standard for BLS and not just add on modules, then they should make the BLS course longer.
Thank you. Dr. Isaacs.
Just in regards to capnography, because the requirement is that the capnography data is stored. So are you able to go back and look at the capnography data? It can't just be with the member document.
So the EMMA capnography does not store.
So that's just a requirement that I believe we have for the.
Requirements for continuous, but not necessarily for recorded or stored.
Yeah, I thought that's always been a requirement for our region. I'm not sure about this.
Oh, I'm talking to the pilot, not specifically to the region.
Okay, but I mean, that's a regional requirement. So is that's different
So
from what we do?
from what I understand, the regional requirement is for continuous end tidal monitoring for airways.
Required to store it.
I don't know that we have to store it. I don't know that it's in our document. I mean, it's possible, but yeah, I mean, again, if it is, we should definitely figure that out. Yeah, Dario and then Brad.
Just a question, were there any identified complications? We required to remove a tube or something, could have been going too far, or went not far enough or too far? Or, because it sounds like every tube was okay. So I'm curious about that.
You mean requirements where they had to remove the tube?
Yeah.
To my knowledge, just if entitled CO2 placement wasn't confirmed.
And we have a numerical, you know how many?
Oh, how many tubes? So for I think out of 18, Jamaica's 18, 14, or I can pull it up.
Christian, if you know the number, you can speak in the microphone.
So using this year as the example, we've had 20 IHL attempts, 18 were documented as successful. That's a 90% success rate that was documented. 14 of the 18 successful had multiple capnography. Of the 18, 16 had a signature acquired, and there was, in the 2 unsuccessful attempts, one was too large and the other was, again, both were too large. I apologize. And when they went to attempt with another secondary size 5 to a size 4, ALS arrived, so they withheld further attempt. In terms of 2024, the issues that I can recall off the top were typically with failing to secure, which also included vomitus in the airway. With any supraglottic, that's always a difficult procedure, so understandable. And then the size being an issue on a couple of occasions. And then there were, if I'm not I'd have to fact check this, but I believe it was 2 that were withdrawn and then ALS attempted intubation. It was not documented as to the reason why it was withdrawn, as some ALS providers will take it out even if capnography is confirmed. But I would have to get back to you with specific data for that.
Great, thank you. Brad? You're good.
Yeah, actually, I had a question, in a very similar vein, which was, I mean, what we're most concerned about are the unsuccessful. So you have, like you said, over about 10%, a little higher than 10% unsuccessful rate, and that's where the harm occurs. So I was curious that, you know, maybe if there's a tube that's in, an iGel that's in, and they're not getting capnography, that's lost time that someone's not being ventilated. So I was just curious. I think you answered a little bit of all those unsuccessful, what's occurring in those, which I think are the key ones to look at. The successfuls are great, but it's the unsuccessful.
There was one successful that did not, documented successful, that did not contain capnography. And of that one, when this was going back to the summer, they were on an arrest where they were told to leave the scene immediately and fumbled with the capnography device. And as they put it, they figured it was better to continue to transport. They had adequate lung sounds. That was thoroughly QA'd. They were told that was incorrect. But that was the one instance where it was documented as successful without any capnography documentation.
That's not successful.
Yeah, but I'm not worried about successful. I'm worried about the ones that
I'm
are.
saying documented as successful.
The 10% that they're saying are not successful. What's the concern is the harm that's being caused in those 10%.
Yes, and so I believe that within the margin of error of ALS also performing advanced airways, it is not outside of that parameter. So if you look at NYMSQA, you can see that advanced airway, which they include intubation and iGel, is not at 90%. It is below. So I believe we are in line with BLS as documenting successfully with capnography documented appropriately, but we definitely need to improve in our documentation with capnography and acquiring the ALS signature.
Okay. Ben, and then we're going to wrap up this.
Just to that, there was a comment there about medics not signing off. I believe our policy for our med is that at least our medics do not, they'll give their information, they'll verify that the iGel is working appropriately, but our medics do not sign off on that, they're not signing off on the iGel.
Okay, thank you. All right. Anyone else want to comment? All right. Hearing. All right.
Just
back
wanted to say
Lauren.
thank you for coming and thanks for sharing your data because like Michael mentioned, we're not gonna learn and make this better without this data and you guys keeping a close eye on it. So thanks to Jamaica.
Thank you. Happy to be here.
All right, Laura, anything else? Back to you.
Yes, next committee meeting is on the 28th at 1 PM virtually.
Thank you. Virtual. Dr. Benelli, you hear that? There you go. Okay. All right, let's go back to our subcommittee reports. Dr. Benelli, medical standards,
Medical standards met,
virtually.
I have the pleasure of standing in traffic today. And, turn it on, please.
Yeah, that's gonna be helpful.
Medical standards met last week, I believe, or 2 weeks ago, 2 weeks ago. And the following is our report. So protocol committee did not meet, so we do not have any protocols that are being brought forward to REMAC for approval. The protocol will have further protocols for discussion and approval in the next meeting, and we will bring them forward. CNC committee did provide a report, and I will let Dr. Barbara present all of it maybe in his section. I will just mention that, I'm sorry? I understood. Okay, we will never forget.
You can tell he's dead. He's
Um,
right here.
The medical standards did approve 3 portions of the changes to the manual that Dr. Barber will present. One of them is terminology change from basic to original, replacing basic with original, that is, and removing provisional candidates, changing the exam schedule from July to December to a monthly schedule, and modifying the ADA recommendations language to match state requirements. So all those were already approved by medical standards and are brought here as second in motion if needed. But I'm gonna allow Dr. Barber to present the whole all the changes in the manual during the CNC committee report. Other than that, the next meeting is gonna be on April 3rd. Oh, no, actually not. The next meeting is gonna be on April 1st, appropriately. At 3 PM virtually. Thank you.
Okay, CNC, Dr. Barbara.
Happy.
Here we go.
And away we go.
Credentialing committee is tasked with modifying the manual as noted by Dr. Benelli. And in a addendum, the CME requirements were requested to be clarified. I mean, I'm in it, Joe. Charlotte. Speak up then.
Just shove it in your eyes.
Dr. Bob said you can hear me. The push for the cycle to mirror the state from a 3-year cycle to a 4-year cycle was part of the manual changes. This was unanimously suggested by the committee and brought to medical standards. And the caveat was to better clarify the category A versus category B CME requirements. This was not within the strict purview of the credentialing committee, so training and ed was involved with a lot of multi-directional feedback. Can we put that table up? Anyone have it? It went out. It's all of your emails on page 9 of the document. There's a very colorful table.
It looks blue to me.
I do love a table.
It's very pretty.
Do we need to show it up or can we just?
I think Pam's gonna put it up.
In the interim, thought of moving this meeting along. Category A is gonna stay the same for its content, but we're stratifying out the categories from either patient care review or didactics based on whether they're synchronous or asynchronous. This synchronous refers to something that's live in person by an educator, by a physician.
Virtual.
asynchronous, virtual counts, because it's about a matter of question and answer. Asynchronous is more of the pre-recorded death by PowerPoint on a learning management system or something like that. And so it's quite deft, I think, that it's the minimum of hours category A by a physician is 18, and a maximum of the hours can be asynchronous at 18. So if you have more than 18 synchronous by a physician with category A, you're fine. But you can only get up to 18 by asynchronous measures over the cycle. And the same content for the category B, which is your ongoing education, device training, onboarding, things like that. There is, there are some remaining topics of discussion, but this is what training and ed and CNC came together in an alphabet soup and present here this meeting.
The totals remain the same.
Totals
Still
remain the same.
36 hours for the 4-year cycle
Yes.
for both each category. That's what I was just clarifying. Any questions? Dario?
Before, so we're doing 3-year cycle now, right?
Yes.
So we
Mazel
have a
tov,
4-year
Dr.
cycle.
You gotta hold the button for a second. So the red light goes on. There you go.
Yeah, so we're doing 3-year cycle now.
We're right now we're 3, we're switching to 4.
We're switching to 4.
That's gonna be voted on.
We're switching to 4 with the same amount.
Correct.
So we're reducing the CME that our medics need to do.
Correct.
I think the issue has to do with the quality of care that's provided by the EMS, EMS providers. They're not very good. If you aren't want to defend them, you're in the wrong place. I worked with them for many years, and due to changes in the population, people, the experienced people are leaving, we're getting new people, different groups, they learn differently, they act differently, they approach patients very differently. I think that reducing that CME effectively by doing this is an issue. And I don't think we're gonna get better care, or they're gonna get numbers and that's about it. If you wanna do it over 4 years, then there should be some sort of time that goes in there and it equates with what we have. Whether it's adding modules that come out of here, EKG readings, which no paramedics can't read EKG. It has to do with understanding the special categories of STEMI, LVO, stroke, and the fact that we do have NSTEMI still. That's a surprise to many people. But I think that we need to start to think a little bit differently. So we're really watering down their education level. And if CME is just getting some numbers, and I appreciate what they've done, but I've said this before, that I think we're losing that time, and it's valuable time.
Dr. Barbara?
So operationally, using annual updates, this body can add additional education as seen fit for those specific items that are part of their maintenance of credentialing, essentially like LLSAs. Now, this content was brought forward with the full backing of both committees with regards to the numbers, as it means to mirror the state. And Dario, I learned from you many years ago, raising standards is tough, but it's important. And I agree with you about maintaining standards. This is the item that was brought. If we want to modify it, I'm happy to modify it, but this is the content that was brought by both committees in unison.
Can I respond? Yeah. I appreciate that. But the problem is, we say we're going to do it sometime in the future, maybe when we get a chance, we'll go around it, and we don't put it in there, it's not gonna happen. And I think, and the medics should not be surprised by this. They should know this in advance. I'm seeing too many MCRs that have really basic issues. We're looking at 15 leads and we can't even read that there's a STEMI.
Right.
I'm discouraged by that. Our manual skills have deteriorated. IJO's probably doing better than the EMTs. I don't think the medics are up that high. Maybe we should replace that. But I think that we need to sort of have that in advance. If you're gonna do that, then that should be part of what they know they have to do, and they shouldn't be a surprise.
Right. No, listen, I hear what you're saying, and, we can always move to change what was sent forward from CNC. This obviously is in line with what the state is doing. It's in line with what both CNC and T&E felt was appropriate. But if you would want to move to say that it has to be more hours, we can make that motion and go forward. Paul and then Ben.
Thankfully, with the learning management system as this, and Kevin has something to say, he's gonna follow me. The ability of the region to understand who is actually teaching what is now codified and documented and tracked. So in years past, physicians in this room have said, I teach CME, but I teach it in my own region. So I agree with Dr. Gonzalez. We should have those learning modules, and I look to the people in this room to provide the content that is so obviously needed as per Dr. Gonzalez and others is feeling. So now we can actually track it, and you can maintain your REMAC credential. You can maintain your REMAC seat by actually contributing to the region in the education form that we need.
Kevin and then Ben.
I just want to say, so what we did, we mimicked what the state was doing by leaving the CME requirement the same from going from 3 years to 4 years. However, the state CME requirement is actually less than ours, so we're already ahead of the state. To sort of back up what Dr. Barber was saying, and the way we're doing it going forward, if it gets approved, is with the 18 hours minimum of category A synchronous. That leaves it up to the physicians to offer more in person, which gives you actually more control of the CME that's at hand if we're worried about the quality of patient care. That was really, it's just, we're mimicking the state. We're already ahead. Is what I went by, I think 10 hours. Ben?
I share Dario's concern about the decrease in hours. And the other thing is, I know you guys did a lot of work on this. I guess the question is, what is the goal of category A? And I think currently, correct me if I'm wrong, but it feels like our goal is to encourage contact with physicians, mainly their individual medical directors, but that's why it's physician directed. And I don't know that I love that they can get up to, as much as half of that time asynchronously. I understand that the medical director is designing the asynchronous. I know this includes the category A that the REMAC is giving. But it really is potentially decreasing the amount of physician interaction. So, my suggestion would be to decrease the maximum asynchronous in category A, like to 12. But what people think about.
Again, I mean, to make it clear, just remember that this is minimum requirements for the region. As medical directors, we can require additional CME and additional training of our crews. That's something that we can do on our own, and I know you guys have a pretty robust training program, obviously. And I think that that's a very important part of what we do. This is the minimum requirement for the region, for regional credentialing.
But in terms of that, and just to be clear, like someone could come to us and say, hey, I have 18 hours of REMAC approved category A between online, and I did this one at this other hospital that gave category A. I don't think we're going to be able to say we're not going to sign off on that. So potentially that person is having a lot less.
That's the thing. You can always say, I don't think this is appropriate for category A. Maybe it's category B, but I think it should be more. I mean, you could say that your category A has to be an FDNY medical director. That you could say as an agency. But I think that, so my question to you though, are you moving that we should change these numbers? If you are, then you can make that motion.
I was seeing if there was support before I actually moved. So if no one's
For
interested.
clarity is, Dr. Zabar, as a medical director, you can approve or deny for your agency as you see fit. That's the role of the agency medical director. If 24 and 12 will get all the handshakes, I think we can move to that. 24 synchronous and 12 asynchronous. But if we want to move to that as an ad hoc, I think we'd support that.
That's Dr. Van Voorhees.
Thank you. Excellent pronunciation.
Thank you.
I just want to point out that there are some great materials that are asynchronous.
mean, just because something is asynchronous doesn't mean it's trash. So have to have, as long as your medical director is looking at what people are doing. And even when we do CME as physicians, a lot of it is asynchronous online.
Yeah, I guess my point is, what is our objective? If our objective is just providing good education, I don't really care if it's synchronous or asynchronous. If our objective, which is why we have category A, or if our objective is we want category A to be physician interaction, then that's a different. So maybe it's not, maybe we should supplement physician directed call review if that's, our objective is not physician interaction.
But a paramedic putting together a case study or case report on a call that they were on and you reviewing it with them as the medical director would be asynchronous. They would do the work and then present it to you for approval. That's asynchronous, but I think that there's a lot of, that's still an interaction, number one, and there's a lot of benefit to that for the providers.
Yeah, I'm not saying there should be no asynchronous. That's what I was suggesting.
So are you suggesting we change the times? Or the-
My suggestion would be the maximum for asynchronous for category A would be 12 hours. If there was
Are you making a motion?
See if anyone would say, yeah, I'm making a motion.
Okay, is there a second for that motion?
Synchronous, max 20 Or, sorry, I would leave the minimum. So the synchronous would be 18 hours minimum, asynchronous would be
12 hours maximum. Is there a second to that motion? All right, Dario seconds it. Any discussion on that motion? We changed the time, so, and this is just the motion, we haven't changed the policy altogether. The motion is to say, where it says asynchronous 18 hours maximum would be asynchronous 12 hours maximum. Yeah. It's the minimum is, you have to have at least 18 hours with a medical director. You'd have to have more clearly because you'd have to make 36 total.
Just want to, if we're gonna raise the minimum from 18 to, I think you said 24. I just want.
No, it's lowering.
No, we're lowering the
lowering
18
the
maximum to 12.
Asynchronous.
I just want to make sure that the onus on that the medical directors in the room realize the onus is on you now to offer more category A's.
So I guess we'd have to change the minimum as well, correct?
I know you do.
Because it has to equal 36.
That's the problem. What everybody else has.
Fine.
Fine.
There you go. Okay, so basically, the motion is the motion, to make it clear for everybody, is to change the synchronous to 24 hours minimum and asynchronous to 12 hours maximum. That is the motion that was made and seconded. Any discussion on that motion before we vote?
Okay, that's for 4 years.
That's over 4 years, correct? So we haven't changed the total. All we're saying is that more time has to be spent direct with the medical directors.
So we still haven't, basically you say you do not want to address the issue of reducing the overall number of contact hours, CME. Now listen, we went from 3 to 4 with the same number. That's called reduction. And our system is just not that good. And I wish we would face up to that fact.
Okay, so the answer to your question, Dario, is no one is saying that we don't want more hours or less hours or anything. We're just talking about the motion that's on the table right now, which is to change those two times to 24 minimum synchronous directly with a medical director and asynchronous, the maximum to 12 hours. The rest we haven't talked about, but that's the motion that's on the table right now. This is only category A. Any further discussion? All right, hearing none, we will vote. And this, I guess, would be, doesn't have to be a roll call, which is not the protocol. All in favor of making that change that was suggested, which is to change the synchronous from 18 hours minimum to 24 hours minimum and the asynchronous to 12 hours maximum, please raise your hand. See one. Anyone opposed, please raise your hand. All right, any abstentions? All right, so the motion fails. So we are continuing with what's on the screen right now.
Now Dario wants to talk about this.
It was, yes. Well, that is coming forward as a second motion, so we don't have to do that. We could call the question.
Dario, you can make a motion. Make a motion to increase it to 48 hours.
Don't tempt him, he'll go to 96 or something.
You want to change it?
Dad, do you want to?
Or
You want to
against,
make motion to increase the
and the
hours?
rest were abstentions.
Yeah,
Okay. Dr. Gonzalez.
I make a motion to increase the overall number of hours to make up for the reduction in hours based on years. Category A.
So what, how many hours would you like it to be?
Well, if you need to mathematically divide it up, what it would have been.
So
And then whatever you
48,
lost, add it in.
So you go to 48 now.
Yeah.
It'd be 24 and 24.
That'd be fine.
So your motion is to change the total number of category A hours to 48 or both categories?
24 and 24.
No.
Category A,
Yeah,
category
category
B.
So there's A and B. A right now is 36 and B is 36. You want to make it
Increase both.
48 for both?
Both.
Okay, so the motion or Dario's motion is to increase the total number of hours to 36 hours minimum for category A. I'm sorry, 48 hours minimum for category A and 48 hours minimum for category B. Is there a second to that motion?
Second.
There's a second. Okay. Any discussion? Done. Paul?
I'd like to bring up back to the committee that this work was done by 2 subcommittees of our group. Close to 30 people had input on this. And I'm the only person besides Mr. Ward here to sit for the committee to bring this presented motion. And I think it's disrespectful to the process that an item comes that's worked on by a small group to be modified at a whim because someone doesn't like it. And I think that it really behooves people to question whether they should be part of small groups anymore, if it's just going to be modified by people who didn't come to the meetings.
So that is a very good point, Paul. Unfortunately, that is the process. What we can do, if this is something that would be interesting to you, because as the chair of the committee, we can send this back to committee to review the motion. We could table this to CNC for you guys to review and discuss the 48 hours for each section, or we could vote on it here.
It was discussed in the meeting, and I would appreciate if we would vote on it here.
Okay,
Because it was
that's fine.
discussed.
I'm just giving you that option, because you're right, small groups should be involved in the process, but this is the process, and if the motion here is changed, it is changed. And we could. All right, so we now
Now we
have to
gotta
vote
vote
on
on the
calling the question. Wanted to do that? All right.
Yeah, I want to do.
Okay, so we're gonna vote on calling the question. So what that means, to make everybody clear on the rules, if we vote to call the question and that vote passes, we immediately vote on the motion on the table. The motion on the table is for this 48 hours and 48 hours. So all in favor of calling the question, please raise your hand. 3, 4, 5, 6,
Joe,
7.
to clarify, I think people were confused.
I'm sorry, go ahead.
Clarify the question that you're.
So
Well, the
right now,
question
we are
ends
calling
debate.
okay, so the rules are like this. There is a motion on the table. The motion on the table is to extend the hours from 36 and 36 to 48 and 48. That's the motion that was Dario made, you seconded.
Yep.
Dr. Bove called the question. What that means is we now have to vote. If the vote is in favor, and if we agree to call the question, we immediately vote on the motion on the table. The discussion is over and we vote. That is what calling the question means. So now, all in favor of calling the question, please raise your hand. Everybody can vote on this because it isn't a change. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20. All opposed, please raise your hand. One opposed.
He wants to debate.
One, well, if you get debate more, you can be opposed.
Some people want to have
One
comments.
opposed. Any abstentions? Okay, seeing none, the motion, now the vote is passed. We will now immediately vote on the motion, which is to extend the hours to 48 and 48. Okay, this is still not the whole thing. So actually, it is the whole thing at this point, I guess, right? All right, so then we'll have to do this by roll call.
No, this is the motion on the amendment.
Yeah, that's right. Yeah.
It's just the amendment.
Just the amendment. Okay, so we have,
Hand vote on this.
so we can hand vote on the amendment. Okay.
Determine out of that 48, how you want that broken down.
No, it's.
No, we, in his motion.
So by the way,
Wait.
just the point of order, when you call the question, ends all debate, which means now you have to vote on
Correct.
every motion down. So you have to vote on the amendment, and then without any further debate, vote on the motion.
Perfect. Okay, so on the amendment, this is a hand vote, and then the actual final motion is a roll call vote. So all in favor of changing the hours to 48 and 48, please raise your hand. 1, 2, 3, 4, 5, 6. All opposed, please raise your hands. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Any abstentions? 1, 2, 3. Okay, so now we have that vote failed. We are now back to 36 and 36, which we will now vote on, and this is a roll call vote. Whew. This is the full thing. On the basically the motion that came forward from CNC is what we are voting on with the one change to the, actually, did that passed? I don't remember. Yes. So with the one change of the 24 and 12 hours for physician directed. Oh,
No, that failed.
that failed.
no, so then everything failed. We're back to the original.
We're still at the original, what you see on the screen.
Fine. So then that's where we're voting. The original that came from CNC. No, unfortunately now we can't. We're voting. She's got to get she's got to know what she's voting on. So just 1 second. It's all right. We're gonna vote right now and be done with it. Or move forward. Okay. Okay. Yeah, so it's just what came forward from CNC is what we're actually voting. I'll go. All right, here you go. Rock and roll. Excuse me.
When I call your, so the motion is to approve the CNC admin manual as forwarded from CNC.
Correct.
Please say if you're in favor, oppose, or abstain. Glenn Aceda,
In favor.
Bradley Kaufman,
In favor.
Dario Gonzalez,
Opposed.
Nathan Reisman,
In favor.
Emma Lai,
Opposed.
Nicholas Alexander,
Opposed.
Doug Isaacs, Jeffrey Raybridge,
In favor.
Reed Caldwell, Michael Rivlin left, Joseph Schenker, Joseph Bowe,
In favor.
here, Mark Cantor,
In favor.
Robert Krupe,
In favor.
Laura Avicoli,
In favor.
Kevin Munjal,
In favor.
Cindy Basilios,
In favor.
Matthew Harris,
In favor.
Jessica Van Voorhees,
In favor.
Benjamin Zabar,
In favor.
Paul Barber,
Same.
David Benelli.
Opposed.
So just so everybody remembers the rules, we need a majority of the quorum in order to pass the vote. So we're going to count and see how many we have. Opposed? Okay, so this vote was 13 in favor, 5 opposed, and 1 abstention. The vote fails. So at this point, this does not pass, even if it's the majority of the quorum. It's the majority of the quorum. Reed did not, he's not here. The majority of the quorum, which is 16. No, you need 16 positives in order to pass. Okay, so you know, I guess we can send this back to TNT to CNC to continue to work on this and bring it back in June.
You know, it's funny because, you know, if you were to allow the state to tell us, we can't even vote on this, but that's irrelevant, right? Because anyway, if we're changing to match the state, can we change our medical control timeline as well to make it 4 years again? Instead of 5 to 3 to 4? We're gonna match, we should match that as well. Is that something you can consider?
I think that's a good point to consider, and if you guys can look at that, and I guess we're gonna make it 4-year cycle, we should probably do that for the physicians as well. What do you think? Dr. Barbara? If you could discuss it with the committee and bring it back to us, that'd be great.
Sounds like we're.
Just want you to be included.
Yes, Mr. Ranieri, Joe.
So the only thing that I will recommend is that since this is going to be going back to committee, the staff will work with the committee to offer an opportunities for members of the full body to submit suggestions or recommendations to the committee, or an opportunity to review the document more thoroughly beforehand, so that this way we can have a more unified effort next time. And then this way the committee has an opportunity to, take into consideration these different points of view before it becomes before the full body.
Yeah, again, we all had a very great discussion here, and I appreciate that. But I think it's really important that if we are going to disagree with the committees, that we should participate in those committees. So please, these committees are virtual. We should take the time to participate and actually give our feedback in real time so that this doesn't have to spin at REMAC. Okay, Dr. Barbara, anything else?
Negative.
Great. Okay, T&E did not meet, so they are going to, they are getting some stroke training from BOT, from the fire department, but it is not ready yet, so they will come back to us with that. And Dr. Berkowitz is not here to discuss the interfacility tag, so we're gonna table that to the June meeting. Okay, Regional Council, there was no meeting. So CMAC Semco update, Dr. Krupi.
Okay, so CMAC Semco met on February 26th and 27th in Troy, New York. Approved CMAC Semco motions included approval of New York City altered mental status protocol. CMAC sending their bylaws to the bylaws committee to provide a recommendation at the May meeting concerning CMAC term limits. Your report, the state medical director position is included in future hiring, and it will take approximately 6 months to a year before that position is filled, and that'll be a full-time position. Multiple trauma center verification and research verification are in progress in cooperation with American College of Surgeons. EMS for Children, the committee is focusing on education modules for scenarios involving pediatric education and developing guidelines for procedural sedation in the ER and field. Additionally, they are reviewing critical care and emergency care documentation and guidelines. CMAC discussed qualification credentialing of an EMS agency medical director, the New York State Department of Health, clarified the Semco that Semco establishes minimum standards through regulations. Regions do not have the authority to credential agency medical directors. However, they can credential system medical control physicians. Regions may develop policies, procedures, and protocols that align with state standards, but cannot create their own minimum standards that deviate from these state requirements. The CMAC can make recommendations to Semco, or an advisory may be issued to provide further guidelines. A tag has been created to draft a document to present to Semco and the commissioner outlining the state's proposed minimum standards for medical directors. Systems, progress continues for the cardiac arrest registry to enhance survival. That's the CARES registry. There's a search for dedicated staff. What else? And I believe that's it. It is a first annual New York State sponsored EMS provider mental health symposium to be held June 9th at the Holiday Inn Saratoga for those who are interested.
Thank you. Any questions for Dr. Krupi? Okay, the region, I mean, obviously the state is saying that we cannot define medical directors in our region. That seems like what they're saying. I think that as a region, we will continue to do that, and we will continue to say what we think is appropriate until such time as they tell us that we can't. I think it's important in a region our size to define what a medical director is, what credentials they meet. And I think that as a body, we should continue to push that and take a stand if that's something that they feel strongly against. Dr. Isaacs.
And Jeff, you might be able to clarify this since you're sitting at the head of the table for the meeting, but the state wasn't aware of their own policy that it does allow the regional to determine those standards. So I heard whispers that they're revoking it, but Jeff, do you know if they did revoke the policy that, their own policy that they weren't aware of?
They have not yet, but when it was brought up that that policy statement existed, the comment from the deputy director was, oh, I guess we'll have to rescind that policy. So I think their recent interpretation from DLA or whatever, that the regions can't do this, contradicts that policy. The conversation then led to, because every region's different, right? And the number of emergency physicians or EMS physicians you may have differ, to perhaps CMAC should create some sort of guidance document setting forth what they believe to be best practice and minimum standards and things like that, but that you could regulate medical control physicians, but not medical directors in the region. But that's where it left off.
Barbara?
Understanding from that meeting, the meetings we had last year, is that other regions in the state were weaponizing credentialing to prevent providers from being able to maintain occupation. And I don't think that's what we're doing here. We're creating standards for safety and a basis standard of care. And I think there is a conflated argument about how these things intertwine, which is why those meetings die off. So I would just, we probably in our best interest to identify what the narrative is, because the idea of credentialing as a negative by the state doesn't appear to be the same reason we have an issue with it here. And I agree with you, Dr. Schenker, should continue to maintain standards of good patient care in this region between the EMS agencies and the hospitals.
Right. And I think one of the things that we can say is, as medical director, individual agencies in this region, we can all agree with each other that there should be a standard. And that is something that the Department of Health cannot argue with. So if us as medical directors of agencies in New York City say it is important that there be a standard for the medical direction of EMS in this city, I think that is a strong argument that all of us agree to maintain that standard. Dr. Sain.
I'm just curious, does this just come back to when we used to have the ADACs? Right? I mean, we felt as a region that we could have the standard, and the state clearly said no.
Correct.
So, I mean, we could agree to it, but we can't be held to it.
Very good point. But at the same time, at that time, they did send a cease and desist and say that we could not define hospitals and so on and so forth. I say that we continue to operate like we're operating until such time as they decide to do something like that. Yeah, Lauren and then Joe.
My understanding is that we have that standard, but that we don't always follow it.
So we do have that standard. We are working to enforce that standard. The challenge is that at this meeting, they stated that we can't do that. That any licensed physician in New York State can be a medical director, which I think we should have a higher standard for EMS agencies in our region. That's the opinion of that's my opinion, and I hope that that's the opinion of most of the medical directors in this region.
But for now, we just can't enforce it.
Well, we're going to until they tell us not.
So the opinion there, I think everyone was in agreement that nobody wants, right, the psychiatrist down the street that doesn't deal with EMS to just sign papers. But the state's position was that the state requirement by regulation is a licensed physician in New York, and that we can't do that. But I think you've heard that, we're going to continue to do that. And state what we think is the standard.
Joe.
Yeah, just to help tie this together, we did bring up at this committee last month, we have pulled together a legislative tag to help fight the fight for us, both at the state and regional level. And this is going to be some of the central work of that tag, which is going to be meeting very soon. Because frankly, if there is any kind of nebulous language in Article 30 as to whether or not we as the region can do that, well, the good thing is we call our state reps and we change the language. The state has no problem adding in their own language, which has become very obvious over the last 3 years. And thus we should be utilizing those same methods to make sure that the state law allows us to adhere to the standards that we want to set.
I applaud that, but I mean, we can't even get, we're not considered an essential service. I mean, come on. I mean, I applaud that effort, but we're not an essential service. It's ridiculous.
I agree with you, Glenn, and I think that the more we take ourselves seriously and the more we define what we think should be the standard for EMS physicians and EMS agencies, the better the opportunity to push that agenda forward to be an essential service and so on. I agree with you. I think this is something that we really do need to fight for and keep pushing forward. Lauren?
I understand the mindset. I think we're generally in agreement, but just to clarify, is the thought that we are doing this now?
We do have a policy in place. We do plan to enforce it. We have been in terms of, we've edited and upgraded our online medical control and physician kind of guidelines in terms of online medical control. This was, I think, passed 2 meetings ago. We are working towards enforcing that with every renewal update. So that is the goal. I mean, again, I think we should have a standard and we should enforce it. Okay. Any other discussion on the CMAC update? Hearing none. Just 2 pieces of unfinished business, and then we'll go to new business. Unfinished business, the STEMI tag that we discussed last month will be meeting tomorrow. I believe it's a virtual meeting at, I think, 1 o'clock virtual meeting. That will be chaired by Dr. Isaacs. Thank you, Doug. And I think Mike Redletter will be helping as well to be involved with it. But anyone else who's interested, please let us know. Finally, the fire department symposium, April 24th to 27th. There are flyers up here. Please take them. Please hang them in your agencies, distribute them so that other people are aware. And that is, like I said, April 24th to 27th. New business? Okay. So that's the unfinished business that we have. Yeah.
I think this is unfinished business. We had an emergent meeting with Mount Sinai Beth Israel today. I was asked to join at 12:05. It started at 12 o'clock meeting. Apparently 30 days ago, well, 20 days ago now, they gave us the 30-day notice that the courts allowed them to shut down. So this morning they got another stay of I guess, execution where they're not able to shut down yet. So they were supposed to go on total diversion on the 20th and then total diversion on the 20th, closure on the 26th.
Just a courtesy.
But the courts have told them they cannot shut down yet, but it's minute by minute, so we don't know. So we're in limbo right now.
We appreciate that. Thank you for keeping us informed. Okay, so that concludes the unfinished business. There's 2 items of new business. I'll let Joe go first, and then I will conclude and we'll get out of here.
So I have 2 items to bring up. The first is I'll bring up the lighthearted one. Just as a reminder, May 18th at 1:00 p.m. at Russo's on the Bay is the New York City Regional EMS Council EMS Week Awards ceremony. So we actually just closed up nominations for those awards. I do want to thank everybody for submitting their nominees. We got a very robust slate that'll be getting voted on at the REMSCO meeting next week. So we have flyers here. If anybody would like information, particularly how you can help sponsor the event so we can have a good time and make it enjoyable for our EMS providers.
Thank you.
The second item I wanted to bring up was a notification that we got today, which unfortunately I did not have time to put into correspondence. As everyone is aware, we are now going on 10 months of not receiving our program agency contracts from the New York State Department of Health. That wasn't brought up very extensively at the state meetings last month as well. So one thing that was announced today was that UBMD EMS program agency is closing down at the end of this month. They are ceasing operations. So that means that there will be 2 REMSCOs in the Western, I believe it's the Western REMSCO and Southern Tier, that will not have the support that they need to actually do their work. So their ability to meet and do training and credentialing and all the things that we do, they don't know how they're going to be moving forward with that. And so I would continue to suggest that folks reach out to their legislative members at the state level and make them aware that this is not discretionary funding. This is required by New York State law that program agencies be allowed to be supported so that we can do our work to support our committees.
Okay, any other new business? Yes.
Staten Island. I got it, John. Staten Island University Hospital EMS will be initiating an ultrasound pilot for preoperative ultrasound. The devices are in the way, and We have no indication of changing any protocols or changing any treatment. It's just gonna be an accession of image transmission pilot phase. Have to report back at the next meeting about this, but there'll be no change in patient care, simply training and image acquisition and transmission in a PHI sensitive fashion. Thank you.
Can you be tracking, on-scene time as well?
We shouldn't have to worry about that anymore, just doing that.
I'm sorry, one more thing, just officially, I just want to thank Dr. Alexander again for all of his dedication to New York City. Thanks.
Okay, final business, and I guess the final piece of business for Dr. Alexandru. We have to vote on our officers. There were no new submissions. The current slate is the same slate that exists. Myself as the chair, Dr. Rabish as the first vice chair, and Dr. Kaufman as the second vice chair. We can entertain a vote at this time. I guess it's either us or nobody, so all in favor of us, raise your hand. Nobody? All right. All right. Nobody, raise your hand. Abstentions.
So we had no quorum.
All right. Thank you very much. Well, no, we do have a quorum. You need to have the entire quorum vote positively. All right, a motion to adjourn. Okay, have a great EMS week, everybody. We'll see you again in June.
It's pretty good. I'm not frustrated. Quite honestly, I'm not frustrated.